So I just want to tell you a little bit about our first panel here and just kind of give you a lay of the land for how this weekend is going to go. Today, really, everything is going to happen in this room. This is really a 35,000-foot view of what's possible, what people are doing. We want you to be able to see yourself in the people on this stage here and see that you can do this all by yourself. We were all in your situation at one point. We have some of the most exciting speakers with us this weekend, but just a few of them to kick us off. Dr. Paul Thomas from Detroit. He's been killing it. He's doing a fantastic job up
Curing
there.
it?
Well, that probably doesn't work in a medical conference. I'm going to have to adjust that one a little bit. But he's just done some awesome stuff in Detroit, and I'm really looking forward to him sharing some of his experiences. Ellen McKnight is a real powerhouse. She is here in Florida. She is an insurance-free rheumatologist. We want to sort of open our umbrella up to some specialists and share. So here in the Panhandle in Pensacola, in Florida, she's a good friend of mine. She's been really good to me and my family, so we really appreciate her being here and sharing her story. Chad Savage. Chad and I went to medical school together. We were lab partners in gross anatomy, and our courses have come full circle. We're both DPC docs. He's in Brighton, Michigan. I won't let his Michigan roots interfere with the program today. So, and Josh goes without any further introduction because. So anyway, I'm not going to take any more of your time. Dr. Paul Thomas.
That's the slide we want. Okay, I'm just adjusting things. All right, they said it couldn't be done. It wouldn't be possible to fix our broken healthcare system. It wouldn't be possible to practice medicine the way it's supposed to be practiced. It wouldn't be possible to lower the cost of healthcare and make it affordable for people in our communities. But here we are, 1,000 doctors strong, and we're practicing medicine on our own terms. We're becoming the physicians that we were meant to be. And our movement is growing, building momentum day by day. People choose direct care because they have access to wholesale medications, at-cost labs, and at-cost imaging services. People choose direct care because they can build a relationship with their doctor. People choose direct care. Sorry, I'm losing the signal on this.
It's a nice map.
Yeah. I don't think this advancing slide is working. I don't know if I have to point in a certain direction. I'll try this again. People choose direct care because they have access to wholesale medications, at-cost labs, and at-cost imaging services. People choose direct care because they can build a relationship with their doctor. And people choose direct care because they believe what we believe, that healthcare should be affordable and accessible for everyone. My name is Dr. Paul Thomas, and I was invited here today to share my vision about what it means to be a family doctor. I also want to inspire you to become the doctor you were meant to be. To get there, I want to share this concept of ikigai. It means your reason for being. I'm guessing that many of you are good at what you do. We have plenty of wonderful, empathetic physicians in this audience who are excellent doctors, right? And a lot of times you're limited by the system that you work in. So it's great doctors often in a bad system. I'm guessing that you get paid for what you do, right? Many of us went into this profession because there are so many benefits to being a physician. One of those is in the system, there's a good amount of money to be made. And oftentimes we're providing what the world needs, maybe. Sometimes it doesn't feel that way because we have such a limited amount of time with our patients. But I'm guessing that you're here because you're in search of something greater, something that you can't quite put your finger on, and that might be your ikigai, or your reason for being. And I believe that when you understand this concept, it can help guide you to a purposeful and fulfilling practice of medicine. So from here on, I'm going to talk about the character traits that I've witnessed in my colleagues when I look around this room, who have the most successful direct primary care practices, who are the most successful DPC docs. And we'll start with our purpose or mission. So going back here, part of this is purpose or mission. So I'm going to focus on this because I feel like it's really important. Knowing what your mission is. For me, I've always wanted to be a family doctor. And that's a lie. I actually wanted to be a Ninja Turtle growing up. And when I realized I wasn't an amphibian, I had to come up with an alternative career plan. And so I started volunteering at a clinic near my house in one of the poorest neighborhoods in Detroit. I was working with medical students at Wayne State and taking care of the most vulnerable patients in our city. And we were supervised by a family doctor, and I was always impressed by his skill, his ability to take care of the most challenging cases. And I wanted to be like that when I grew up. I wanted to have that level of skill. And in medical school, I became acutely aware of the lack of primary care resources in my city. There are fewer than 100 primary care physicians for 630,000 residents. That means there's one doctor for every 6,300 residents in the city of Detroit. And so all these areas, these pink areas on this map, are underserved regions of the city. So virtually all of Detroit. And the irony is if you go north of 8 Mile, or just to the north of Detroit, out of Wayne County into Oakland County, they have one primary care physician for every 600 residents. So it's a 10x disparity just across 1 mile road. Because of this, my classmates and I built an outdoor medical clinic. We were going to solve the healthcare crisis. For us, it poignantly represented the healthcare disparities in the city and our idealistic hope to solve them. I went into medicine wanting to help people and to serve others, and I wanted to address these health inequalities, and I wanted to make a difference for my patients. So for me, that's my purpose, that's my mission, that's why I'm here. But the further and further I got in my training, the less and less time I was able to spend with my patients. And you all know what this feels like, right? It's probably why you're here too, right? You want to know how you can actually take care of your patients. Being a primary care doctor is like trying to catch sand, with each grain representing a patient concern. There are only so many concerns that we can take care of before problems start slipping through our fingers. And that might be your mom's Alzheimer's, or your brother's chest pain, or your daughter's sore throat. And when your patient panel is at 2,500 or 3,000 patients, those are a lot of grains of sand that are slipping through our fingers. So prescriptions go unfilled, screening tests are missed, and in many cases, the basic healthcare needs of our patients go unmet. Worse still, as was mentioned previously, doctors are feeling burnt out and wanting to leave the profession. A recent study from the Mayo Clinic confirmed what was said earlier. 54% of physicians are feeling that burnout. And I was burnt out, and I hadn't even finished residency yet. Like, I wanted out so bad, I can't even tell you. I was worried that I'd be trapped in a system that undervalues primary care, that undervalues human relationships. I was worried that I would be trapped in a profession that was slowly losing its soul. Which brings us to our second topic, passion. So, doing what you love. I knew that I would never be satisfied by checking boxes in an EMR or fulfilling the quality metric of the day. I wouldn't be satisfied by practicing medicine in a system that gives me only 8 to 12 minutes with my patients. I knew that if I were to build a fulfilling practice and a fulfilling life for myself, it would have to focus on my passion of serving others. You see, I was most fulfilled at that clinic for homeless folks and underserved folks in my neighborhood. 30 minutes to an hour with these patients, really understanding who they were, what their concerns were, and how we could best help them to the next step in their lives, making a tangible difference for them. That's what turns me on about being a doctor. That's my passion. I also knew it was important for me to have an impact beyond the individual patient. I wanted to serve a community that was left behind by the traditional medical system. And I kind of mentioned this before, but in a different context, a lot of the healthcare systems choose to locate their offices and hospitals in the wealthiest neighborhoods, right? Because they make the most reimbursement when they have the wealthiest patients. And this is a map from the city of Detroit, health professional shortage areas, those HPSAs. And there are virtually no hospitals or branded, large health system outpatient clinics. So even if I wanted to sign on as an employed doc, I wouldn't be able to be in the neighborhood that I wanted to serve. This often leaves the poorest neighborhoods medically underserved, and in Detroit, where residents lack access to reliable transportation, healthcare becomes geographically out of reach. So this is my passion. This is why I serve and why I solve these health challenges. This is why it's important for you to find your passion. Starting a direct primary care practice has been the most challenging, but also the most rewarding thing that I have ever taken on. And for you, it will require a tremendous amount of time, energy, effort. So if you're working on something that you're not really passionate about, you're not going to reach that sense of fulfillment, that reason for being, that ikigai that I mentioned earlier. The next step in being the doctor you were meant to be is to be authentic and practice with authenticity. This movement is made up of individuals doctors who have their own strengths and weaknesses, their own personalities and characteristics. Some of us have built our own electronic medical record just for the purpose of taking care of patients, with an emphasis on taking care of patients. So thank you, Josh, man. Some of us have started some sort of healthcare co-op. I keep hearing about this on Hannity.
2019.
Yeah. Oh boy. And some of us have spent 20 years working on direct primary care over the last 8 years. You're aging well. You're aging well, my friend. Some of us have learned second and third languages in order to better communicate with the patients that we serve. I tip my hat to people like Rebecca, who have learned Spanish and who are now actively learning Portuguese to do just that, take care of her patients. It's amazing. Some of us give rousing speeches to open conferences. This is never going to die. And lose their shirts in the process. You know who you are, Jeff Gold. Salveo, #Salveo. So my message is to be authentic and understand your strengths and weaknesses. When you're working under one of those large healthcare systems, the personality of the doctor is often discarded. Like he said in his presentation before, you're often labeled as a provider. You're not even to be a doctor. You're intentionally confused with someone else with another professional title. You become this replaceable cog in the machine of the healthcare industrial complex. But you're not a cog. You're an irreplaceable, dynamic, complex, empathetic, loving, and caring physician. You're my colleague. Because you are a DPC doc, you can embrace the unique aspects of your personality that make you a great physician, that will allow you to practice medicine the way you want to practice medicine and not the way you're dictated to practice medicine. Be authentic, be you, and your patients will be drawn to your unique personality and your unique practice. Next, care. That's it. Care deeply for your patients. I don't think I can overstate this, the importance of demonstrating genuine care for your patients. But if you want to become the doctor you were meant to be, you now have the time to demonstrate that care. I'm going to repeat this. I'm going to say it normally, and then I'm going to use my movie voice. In a world where patients are rushed through appointments, treated as the number on the back of their insurance card, and given the opportunity to ask only one question of their physician, you can stand out boldly by doing one thing, and that is caring. So you ready for this? In a world where patients are rushed through appointments, treated as, no, you get it, coming this fall. So what does that look like? It looks like meeting your patients at the door or in the parking lot and shaking their hands on their way into your office. Who does that? Direct primary care doctors do. It looks like taking the time to explain what it means to have diabetes and how to best take the medications and how to manage it completely. It looks like taking the time to actually get to know your patients, know their personal lives and how they're feeling in the context of a new diagnosis. It looks like going the extra mile and getting that lab test or medication or imaging study that was previously out of reach for them. And here's a fun one. It looks like coming in the middle of the night sometimes and being the hero, right? So I was at this event, gala, 150-year celebration for Wayne State University School of Medicine. And I was in a tux, black tie, and one of my patients had cut off the tip of their finger, and they were profusely bleeding. I got a call at 10:30 that evening, and they said, it's a restaurant that signed up with our practice, and they said, one of our employees cut the tip of their finger off. And I said, I'll be there in 20 minutes. And it really only took 10 minutes of my time and some dry sol applied gently to the tip of the finger, and it stopped bleeding. They were so happy. And they also brought sake and dumplings because I work at a restaurant, and my wife was thrilled. She was like, this is the best thing ever. It's amazing. It looks like following up with them via text message and asking them how they're doing after they left your office. So this is a true story. We were on Channel 7 Action News in the Detroit market, and they said, oh yeah, just have a normal text conversation with your patient. And I sent her a text message that's not awkward at all that says, tell me more about the thing. That's normal. That made it on air. Oh boy. And the best part about all of this, about caring deeply for your patients, is that it comes naturally to you. You're a doctor because you actually care about people. You have this deep-seated trait for caring for people, and it's probably one of the biggest reasons why you chose a career in medicine. And now in this model, as a DPC doc, you actually have the time to demonstrate your care without restriction and without limitation. So we've talked about purpose, we've talked about passion, we've talked about authenticity and caring. These are all the things that can help you get to that doctor you were meant to be, that ikigai, if you will. Now I'm going to challenge you on one point. I want you to tell your story and communicate your value. What this movement needs now, more than ever, is to communicate the value of having a doctor who is looking out for the best interest of the patient. We as physicians know our value. We know how good we are and how caring we can be when given enough time and space. When we no longer are restricted by health bureaucracy or insurance red tape, we can deliver the sort of care that we can be proud of. And there are thousands of physicians across the country doing this every day, and so many amazing stories that we can tell. Because patients are craving this sort of value that our practices provide, when they hear the message from the individual physicians in their community, it resonates and our movement grows. When they hear the message from NBC News, it resonates and our movement grows. When they see us on Sean Hannity, the message resonates and our movement grows, including the bodyguard. When they hear the message on National Public Radio or they see us on Medscape, the message resonates and our movement grows. So here's my challenge. What stories can you tell? What are the stories that are going to resonate in your community? And oftentimes it might not be from you, it might be from your patients. Those are always the most powerful. How can you communicate your value and tell the story of your impact? Because we need you. For this movement to grow, we need you to lean into storytelling about your patients and what you do for them. What it means to have an empathetic and caring physician with the resources and time to make a big difference. So I think this was Jay-Z who said, no, it's Seneca. Luck is what happens when preparation meets opportunity. The more you get out and speak in your community, it might start at the Rotary Club, but you might meet somebody in broadcasting and they might invite you to be on the nightly news or on the radio. It might start there, but I believe that somebody in this room is going to make it big for us. They're going to be the next person on NBC Nightly News or on Morning America with Michael Strahan, or my favorite, you're going to dance onto the Ellen set, and you're going to sit in the white chair across from Ellen. You're going to tell her about the value that we provide to our communities as physicians. And Ellen, if you're watching, if your staffers are watching, I've been working on my dance moves. I'm ready. So in summary, direct primary care gives you the opportunity to practice with passion and purpose. It allows you to be your authentic self and give the time and demonstrate the care for your patients. It is the most unique opportunity that we have in primary care medicine, and if done right, you can find your ikigai, or your reason for being. I believe in family medicine. I believe in primary care. I believe in the direct primary care movement, and I believe in you, the doctors in this room who are fixing our broken healthcare system from the ground up. You can be the doctor that you were meant to be, and it starts today. One day or day one, you decide. Thank you.
That was excellent, very inspirational for primary care, but also for specialists, so thank you very much. I'm really delighted to be here today among this group of what I'm going to call happy warriors. That's really nice for a change, because if you've been to medical meetings lately, they're really not as joyous as they used to be. But I'm sensing something different among this group of doctors. I am especially grateful to Dr. Lee Gross for inviting me to be with you today. We are presently witnessing a movement of courageous doctors staking a claim to what is rightfully theirs, and in doing so, they could save our beloved profession. The direct primary care movement and the free market medical revolution has the potential to put the natural order back into medicine. But putting the natural order back into medicine requires doctors to believe in themselves, to believe themselves to be the possessors of everything that it takes to reclaim medicine. Physicians actually have it, but they don't believe it right now. And that's because we have been attempting to practice medicine under a form of feudalism, the physicians being the present-day vassals, the administrators and the bureaucrats being the present-day lords. Sadly, physicians now believe the only way to survive practicing medicine today is to have the protection of those who are currently lording over us. But that protection has come at a very high price. In a feudalistic practice, the physician vassals are assigned a small plot of office space, a few staff, and the latest incarnation of the interminable EHR. We are then expected to continually till the soil of patient care and to bring to our protector the financial fruits of our labor. We are allowed to keep a small percentage of what we collect, but the rest is taken as the price to practice medicine. We must also give to our overlords the respect and reverence they feel they deserve, lest we be labeled disruptive physicians. You see, a silent, dormant vassal, one who does not challenge their so-called protectors, would be the most prized vassal of all. But if we remember our history, feudalism failed centuries ago as a construct for a functional society. I believe we are seeing the same fate befall medical feudalism, because it too is a failed construct for a functional healthcare delivery system. But how do we get physicians to reject medical feudalism and to adopt the free market? I believe it will require a drastic change in the mindset of most of our physician colleagues, as was the case in my own life. It was just a few years ago that I was in what I would describe as a deeply dormant phase of my professional life. I stayed silent throughout most of my career on the important debates surrounding the economics and politics of medicine. Most of us made a purposeful choice that we would focus on taking care of the medical needs of our patient as our oath obligated, rather than taking on the bureaucrats and the administrators. Well, here we are today, overworked, unfulfilled, and being labeled as burned out, beholden not to our patients, but to these very bureaucrats and administrators. There was an issue, though, that jarred me out of my dormancy, which motivated me to activate and to become what I like to call a defender of the profession. That issue was maintenance of certification, an unproven recertification mandate which effectively takes the lifetime medical doctorate and converts it into a 2-year certificate. Although MOC initially motivated me to activate, I quickly realized that once you stand in defense of the profession, you are not standing up for just yourself. You are standing for other doctors. You are standing for other doctors. It's really not about you. It's about your fellow physicians. And I came to understand that once activated, there is no turning back because you love the way it makes you feel. It gives you an energy that many physicians are lacking right now. To be perfectly honest, standing in defense of the profession is downright invigorating. But what makes our profession worth defending? Our profession is one of the original great learned professions, and there were only 3: medicine, law, and theology. A learned profession is characterized by the accumulation of extensive knowledge and a willingness to teach and share that knowledge. There are obligations that come with being a member of one of these learned professions. There is an obligation to the client, or in our case, the patient, to the community, and to the profession itself. And I believe that is our biggest obligation at this time, the obligation and commitment to our profession. We are obligated to attempt to wake up this dormant giant, and by that I mean the entire house of medicine. We want all physicians to discover what we now know. There is a better way. But physicians have been dormant for a very long time, and unfortunately, many have become comfortable in that state. I would like to spend a few minutes discussing this concept of the dormant physician, something which afflicted me for most of my 30 years in medicine. The good news is, it's curable. The definition of dormant is something that is not active, growing, or being used, but is capable of becoming so. When I speak of the dormant physician, I am speaking of our physician voices not being used to speak out in defense of our profession, and of our inaction as physicians in fighting against conditions which we know denigrate our profession. I ask you to think back to your medical school days and answer the following. Would you have thought then that you and me and most of our fine colleagues would be so silent as our great and noble profession is being destroyed, as profiteers have overtaken the profession of medicine and are using our skills to profiteer off of the patients that we are committed to treat and that we have taken an oath not to harm? There is a reason we are so silent. It is because we are in what is called consequential dormancy. What do I mean by that term, consequential dormancy? Well, there are species out there that don't normally go dormant. It's not part of their normal life cycle. However, they will go into a dormant phase as a consequence of adverse conditions, essentially as a survival mechanism. I believe physicians have been driven into dormancy as a consequence of the many adverse conditions we face. What are these adverse conditions? Well, as we also like to say in medicine, they are too numerous to count, so let me just name a few. MACRA and MIPS. The enormity of this regulatory morass presented to physicians and the country as the so-called doc fix is truly incomprehensible, and it has already been proven to be failed policy. ICD-10, formerly ICD-9, and the loss of our medical language because of codes. Third parties, including Medicare, which have now taken the doctor's orders and made them doctor's suggestions, which I contend aren't even taken seriously. Your doctor's orders are promptly ignored the moment they are written. These same parties use language to promote themselves as payers when they do any and all things to avoid paying. A more accurate descriptor might be denier, interferer, or delayer, but payer, I think not. RAC audits, penalties, the fact that we, among the most highly educated and skilled professionals in this land, ever allowed ourselves to be penalized for not doing the latest Color in the Lines project by CMS is a complete travesty. HIPAA, which shuts down doctor-to-doctor communication but allows the free flow of patient data to any and everyone else without the patient's knowledge or consent. MOC, if we physicians are forced to maintain our certification every 2 years, learning things we don't need and relearning areas of medicine we do not practice, there will be no time for anything else, much less the defense of our profession. Certificate of Need, stark prohibition of physician-owned hospitals, which doesn't allow for doctors to profit. Most doctors tend not to profiteer, but these laws encourage non-medical entities to do just that. They profiteer off of our skills and off of our patients. Politicians and health policy wonks who devise and pass legislation such as the HMO Act, the Health IT Act, ACA, MACRA, and MIPS, just to name a few, which effectively transforms our exam rooms into the laboratories of absurdity. These same politicians allow for and encourage the encroachment of individuals into our learned profession who have not acquired the extensive knowledge and skill that has been the standard for our profession. The EHR, that's the one that I want to focus on because I do believe this is the biggest threat to our professionalism. The EHR has destroyed the doctor's note, taking a once relevant, succinct, and honest document and turning it into the exact opposite, a dishonest, voluminous billing or coding record filled with irrelevant junk data that the physician is forced to enter. The government-mandated EHR has profoundly denigrated our profession, and it completely demoralizes physicians. And I believe it is the main contributor to the epidemic of physician burnout. I do not believe burnout is because physicians are working hard. That's kind of in our DNA. It's what we do. But our work has to have meaning, and because of the EHR, the work we are now doing is meaningless to physicians. The EHR indentures physicians into a servitude where they are doing 6 to 10 hours of uncompensated work a week. That works out to 4 to 6 weeks a year. The AMA recently tweeted out an article describing the 83 minutes a night that family physicians are spending at home doing tasks on their EHR. Instead of calling this an abomination and calling for the end of the EHR, the AMA chose to term it pajama time. I've also seen it referred to as date night with your EHR. I guess they were attempting to be funny in describing this, but frankly, I don't see it as humorous. When a physician provides uncompensated care to patients who are unable to pay because they are poor, that is a noble act. But this is not uncompensated care. This is indentured labor, which in effect props up health IT and their junk product, and they have no impetus to change it because it is government mandated and because they are getting free labor. If one looks up the meaning of indentured servant, it will sound very familiar to physicians who use the EHR, but there is a glaring difference. In the past, an indentured servant eventually was freed from their servitude and commitment, and they had in return worked for something of very great value, such as American citizenship or the right to be brought to this great land. Physicians will never be freed from their servitude to the valueless EHR unless we just all decide to say no more. I recently tweeted on this topic, which is something that I like to do, and it said, in medicine, if we discover that something doesn't work or causes harm, we end it. We just stop doing it. But with a government mandate, a bad idea is forever. #ditch the EHR. You see, our silence and our inaction works to the advantage of some, as I have just pointed out, and those entities like us in our dormant state. But I suggest we try something new. We need to rise out of our dormancy. We must activate in defense of our beloved profession, and each and every one of us must become defenders of the profession. We need to come forth as a profession and say this simple but powerful word, no. Our professionalism, our oath, and our medical ethic demands that in unison we say, we are physicians and we don't do it that way. But can we be so bold? Can we just say no, and can we really take it back? Yes, I believe that we can, because there is a truism about physicians, which some of us seem to have forgotten, or maybe we've never known it, or we may just have never thought about it. But here it is. It is the physician who possesses the knowledge. It is the physician who has the skill. And that knowledge and skill is always with you. So where you go, it goes. It does not stay behind if you decide to get out of a situation which forces you to do things counter to your oath. All of your education, your training, and now your experience is yours, and it has enormous value. No one else can do anything without us, frankly. We're the ones with the knowledge, and they, insurance companies, government, pharmacies, corporatists, health IT, administrators, and yes, even the patients are the ones with the need. We're the ones, however, who have taken the oath. We are the ones with the responsibility to our patients and our beloved profession. And that's exactly why we must take it back. Well, all we need to do is to look right here in this room and to this movement. Don't you remember the predictions about primary care? Primary care doctors were going to be a thing of the past. They wouldn't be needed. The primary care doctor was going to be easily replaced by non-physician extenders. Well, that's all wrong, as we now see. The independent, direct primary doctor has said, forget you to insurance companies. They've said, forget you to Medicare. And they're saying, forget you to mega corporate pharmacies because they are dispensing medication right out of their own offices. They are taking their valuable knowledge and skill set directly to the patient, and it is revolutionizing care in a 21st century way. But it is also going back to a kind of traditionalism, because that's the way it used to be. The doctor and the patient had a very direct relationship in all things, including payments, and there were no superfluous intermediaries whose only role today is to profit off of our skill sets and off the backs of our patients. The direct primary care doctor is now rising out of their dormancy to show us how it can be done. And they are setting the example for the rest of the physicians of this nation. They are reclaiming their rightful role as primary dictator of patient care and as the most vital physician of the entire team. These independent physicians no longer need protection from bureaucrats and administrators. They are now their own protectors, standing for the sanctity of the doctor-patient relationship and in defense of the profession. The natural order in medicine returns the primacy of the doctor in all aspects of patient care. But my caution to you today is, there are challenges being made against this movement, which would transfigure the purest model of DPC to once again introduce intermediaries. The key is you don't need middlemen if your prices are kept fair and you provide what the patients want and need. Easy, timely access to their physician and true quality care provided by someone they trust. So I'll wind down with this thought. On a recent visit to the Reagan Library, I learned of a plaque that he kept on his desk during his entire presidency, which said, "It can be done." I've thought about that a lot because we often hear that medicine is too far gone and that doctors are powerless to change it. Well, I suggest to you that it absolutely can be done, but we need to rise out of our dormant phase to become defenders of the profession. If we stand for the profession of medicine and we do what we know is right for it, that automatically translates into what is right for our patients. It's the way that it works. The two are intertwined and they cannot be disassociated. That bond is forever. So for the rest of my medical career and maybe beyond, I am committed to advance the concept of the activated physician and to encourage every physician I meet, including each and every one of you, to become a defender of our great profession. Thank you very much for having me today.
I was really hoping to go after Chad. That's a much easier speech to follow. Those two did an amazing job. You have to ask yourself, why? Why medicine? Why the hard work? Why the stress? Why travel to Orlando and leave your family and your lives behind? Well, partly because it's a tax write-off, but I think we have the best why ever, and that's our patients. Simon Sinek has a fantastic book and a TED Talk by that title. Our why is what drives us. It's what leads us through those hard times. And medicine is hard. And it's harder than it needs to be because we've allowed all of these extra things to get in the way. But there's a path, and there's a path we can all follow. I want to read JFK's quote about the moon. We choose to go to the moon. We choose to go to the moon in this decade and do the other things, not because they are easy, but because they are hard. Because the goal we serve to organize and measure the best of our energies and skills. Because the challenge is one that we are willing to accept. One we are willing to postpone and one in which we intend to win. And I think we intend to win the reinvigoration of medicine for ourselves, for our families, but most importantly for our patients. We can empower ourselves to take responsibility for a broken system. And I think for a long time we've blamed everyone else. Well, government is bad or insurance is bad, and those might be separately true. But it is first and foremost our job. We're the gatekeepers, we're on the front lines. And if we don't fix it, if we don't figure out how to fix it, I'm not sure how a payer would. So we need to take all of our training and all of our experience and work together and problem solve. And often that means streamline and simplify. Umbehr doesn't make things more complicated, they make them easier and faster. And they have this explosion of value that everyone benefits from. If direct care looks at our patient population and says, how can I help the patient in front of me? And we say it's our fault if you can't afford your medicine. It's a little scary, but it's also very empowering. And now it's my job, my ability, my opportunity to go forth and find a solution and find wholesale meds or contract with the labs to make medication 95% less. Or to find a way that you can do procedures for free for your patients so everybody, regardless of income, can get great high-quality care. It's the most noblest thing we can do. If we take our oath seriously of do no harm, that has to mean do no financial harm. And forever we've held ourselves back from that role in a business sense. And we've left that up to administrators, and we've gotten the system that we built. And we don't like it. So let's tear that down. Let's build something new. The best companies are figuring out ways to remove barriers and improve value. And medicine can do that and be very proud of that. The CEO of Costco says every good idea we've ever had, we've stolen. I've stolen a few good ideas from Paul and Lee. I don't know about Chad, but I'll get there eventually, maybe.
I get the microphone last.
I'll skip out my last joke then. But it's very empowering because there is no plagiarism here. Each doctor innovating can share that with everybody else. If you want to go fast, you go alone, but if you want to go far, you go together. There's 300 plus doctors at this conference new to the DPC world and eager to learn how to do it. There's 50 plus experienced DPC doctors here eager to share what they've learned. They've made all the mistakes. They've struggled through that. And we can pass that knowledge on because every doctor we help is an extension of all the patients we can help and the families we can help. This is the noble thing that we can do. Some would have you believe that by dropping insurance, you're abandoning patients. And what I'd say is we're really finding them again. We're making them our top priority. They are our why. And it may be hard. And it may seem impossible. You can't fix healthcare. You're just one vote or just one doctor or one person. But every one we have is 600, 700, 800 patients we can help. That's lives that change because now I had a patient email me this week about the year she struggled with her migraines and would fight off going to the ER and getting a big bill because she was afraid of how that money would no longer go to her children. And then she had a migraine, and we treated it for under $5 with Toradol, promethazine, and Benadryl, and she couldn't believe the years of suffering she had because of the fear of a big bill. And DPC can fix that. We can problem solve. We're removing barriers away from our patients and their care, and we extend that out at every level. It's an invigorating opportunity to help yourself, to add value to your own world. But again, we have the best why, and that's patience. And when this started 10 plus years ago, people thought it would never work. And everyone can say that. The critic, no one builds a statue to the critic. You know, they want to look at it from a negative perspective. They want to say how it couldn't work. But we have to look at it and say, how could it work? How can we make things better? And although some people choose not to believe it, this movement has grown because we stand on the shoulders of giants who are figuring it out daily in the war zone and coming out better for it. So we want you to feel like when you're done with this conference that you have a better understanding of the value that direct care brings to everybody. If we can beat drums like that, it's storytelling, it's value opportunity, it's passion. Patients will follow your passion. And if you're burnt out and you've lost your empathy, why would they value you in a model where you only give them 7 minutes after being an hour late? You know, we're devaluing ourselves and we're devaluing the product that patients receive. But instead, if we give them an hour, if we come in a tux, you know, a tux is a very nice suit, Chad. Not that Kansas is leading fashion or anything here, but they'll go and tell other people. They'll tell people for years that story. My doctor cared enough to come in at night, help me out at my greatest moment of need, probably for free or next to free. They were so grateful that they brought gifts. Who brings an insurance doctor gifts, you know? And if they do, it's because you're trying so hard in a broken system that they appreciate it, but you're still Michael Phelps swimming with bowling balls. You can't even be your best in a broken model. So now that we see that this is possible, there's a great example, Christopher Columbus's egg. And he comes back and he discovered the New World, and they said, well, anybody could have done that. So he takes an egg, he puts it on the table, and he challenges everyone to make it stand up. And all the king's horses and all the king's men say, it's impossible, an egg won't stand up. He takes the egg, he crunches it, and the egg stands up. And that's the magic of simplicity. We went from something that was impossible to now it's so mundane, anybody can do it. Direct care is the impossible made simple. There's another story about Napoleon's aluminum. That aluminum was so rare that if he wanted to impress dignitaries, his generals ate off silver, he ate off gold, and the dignitaries ate off aluminum because it was so hard to get it out of bauxite. Then electrolysis comes along, a new technology changes the entire way that we deal with the product, and it becomes aluminum foil that we can throw away. We don't want healthcare to be thrown away, but we take it from something so rare, so troublesome, so expensive, we have to insure it, and we add in a new technology, a new business model, a new way of thinking, and we make it so affordable that now I can get 1,000 hydrochlorothiazide for $4.90. It's silly. The label costs more than the medicine. The stamp costs more than a month of medicine. You know, that's the amazing thing that we have. We have this opportunity. We can make cancer medicine $6 a month. You know, and if we can, we should. If we're not doing that, then we're complicit in a broken system, and none of us want that. That's the soul-crushing reality that too many doctors are in. So if we know that we can bring value to our patients and we embrace innovation, the rest of the world embraces innovation to the point that we have supercomputers in our pocket. It's amazing. If I drop this in the toilet, now it's waterproof, but if I drop it, I can go to the supercomputer store and pick out a new one. If we embrace that, then what kind of impact will we have on our patients? If we save them $200, $300, $400 a month, that's college tuition paid for a family. So because a patient was buying Imitrex for $200 a month and now can get it for $5, you could pay for that kid's college tuition for a first generation family just because you found a way to innovate a better system. That's our why. Patients are the best why that any company can have. If we put them first, we really can't lose. So thank you for attending. I hope you feel like you've learned a lot. Ask all your questions. It's going to be an exciting couple of days. Thank you.
I love that guy. I love him like a brother. They wrote a story about it. What, Cain and Abel? Cain? Yeah, love him. You know, I have to admit, I actually did take all of Josh's good ideas, and actually I'm incorporating a lot of them in my talk. You know, all of Josh's good ideas. It was probably about the most fascinating 23 seconds of my life. You know? Yeah, but yeah, but you know, he really did have a big role. I mean, look at this. He was a major factor in all of this. And if Josh was a major factor in all of this, imagine what someone who is competent could accomplish. Okay, I actually have some really important points I want to get to the end of the slide, so I'll defer to the Q&A for insulting him more. Okay, yes, for those who've been here in prior years, I'm that finance guy. Yeah, so my job is to try to describe for you why direct primary care can save money and why the costs, the fake costs that are permeating our system are so important. I'm having Paul's issues too. What am I missing? Point it there.
Yeah,
Take that. No?
The green button.
A green button. Take that green button. No, maybe not.
Now who's the confident one?
Tech guy, making me look so bad. All right, well, I'll just start talking as you try to figure that out. So before you can explain why direct primary care can save money, you have to understand what direct primary care is. Now, as almost all of you understand who are here, direct primary care is a membership model of medical care. For a low-cost monthly membership, I'm not killing people's eyes here in the first row with the laser, am I? For a low-cost monthly membership, usually about $40 to $100 a month, people can get unlimited primary care visits to their doctor. Now that is imperative, and the reason why is people, when they pay a lot of money at the time of they see their doctor, they're disinclined to actually see that doctor. So what does that mean? Well, they do save money in primary care, that's right, because they're using them less. However, they're doubling that savings in new costs of hospitalization. And that's not only a cost issue, that's a human suffering issue. It also includes all in-office diagnostics, EKGs, spirometers, pulse oximeters. We get away from the nickel and diming of charging for every little test that goes through our system, and we actually try to give people value. It includes all in-office procedures, joint injections, biopsies, and it includes what I think is most revolutionary, which is telemedicine. The ability, whoa, now I'm like in the middle of it. Okay. Do you want to go back? At least the big surprise that the embarrassing picture of Josh hasn't been put up yet. So this is all good. All right. Yeah, there he is. So, okay, yeah, wow, what an awesome slide. There, you guys see it now. All right, so that was everything I was just describing. All right, so, with direct primary care, we include an incredible bundle of services: unlimited visits, in-office diagnostics, telemedicine, in-office procedures. But then we take that incredible suite of services, and to magnify that benefit for that low monthly expenditure, we have gone out and we have negotiated predetermined prices on cardiac diagnostics, labs, imaging, and even for many of us who can dispense in our states, generic drugs that we dispense from our own offices. And we do this to try to magnify that savings. And the concept is we want to save those people so much money that our membership essentially becomes free to them. They get all of their primary care for what they would have spent anyway with the overpriced services that are currently in the system. So for example, in Michigan, a common price on an echo stress is about $2,000. We can get it for $200. That's a savings on one test of $1,800, or depending on the age of the patient, the equivalent of almost 4 years of direct primary care. Unlimited primary care for 4 years of the savings on one test. And we see similar savings on other types of services too, including imaging. Now this is an important slide. I want you guys to kind of take a look at this because I'm going to come back to this a little bit later. Our local hospital, our university hospital, has a transparency website. Thank you very much. They tell me what they charge for these things. They charge for an MRI $4,200. We can get the same MRI for $279. That's a savings of $4,000 on one test. That you justify your membership in the DPC practice for 8.3 years with the savings on one study, the better part of a decade, threw in primary care for free by correcting the pricing on one study. We see this with x-rays, another 1.25 years of savings. We're 93% cheaper than the local hospital, $529 savings. And we see this with ultrasounds, $1,000 savings, where you get 2 years essentially thrown in for free, and bone densitometry. And I apologize if I sound like a podcast running at 1.5. I got the message that we were running a little behind before I even came up here. But that's okay, because you guys are recording it, so they can play it back at 0.5 and it'll make sense. So we do labs. We do something called client services billing. We send the labs to the laboratory, who charges us the prices they generally speaking give hospitals. We then act as a financial conduit to give those prices to the patients, things they could never ever get on their own. These are our hospital prices. 4 basic, these are not crazy tests, 4 basic tests. $135 for a lipid panel, we get it for $5. PSA, $152, we get it for $7. They charge $544 on one blood draw, 4 basic tests, for something that we can get for $23. That's a savings of $520. They charge 24 times as much as we do, and you just justified another year in your DPC practice on one blood draw. Now, I don't have comparators for these, but with the in-office pharmacies, they can get incredible savings as well, and these are just some examples. You can get a month of Zocor, treat hyperlipidemia, for 73 cents. We can treat depression with Celexa for 54 cents for an entire month. You can treat an episode of pneumonia for 89 cents. You can treat hypertension, one of the leading causes of preventable death, for an entire month for 21 cents with Norvasc. You can treat one of the leading causes of premature death for an entire month for less than the cost of a single gumball. So now, okay, so we give incredible services. We merge that with many, many cost savings. So the best way for people to really achieve maximal savings is to join this with inexpensive coverage options, high deductible PPOs, Christian health sharing organizations. For businesses, they can self-insure with ERISA-based plans and design them around DPC, and short-term policies, which are really starting to come back. They're kind of like the recurrence of the catastrophic plans, and as I understand it, you can now renew them out to about 36 months. Now, before I go into how these things all link together, I want to take a moment to break what I call the fallacy of good insurance. Many people say, well, I don't need to see you, DPC. Doc, I have quote-unquote good insurance. Well, that person does not have good insurance. They have overpriced insurance, and I believe this graph illustrates this. If you look here, this gray that you see, that is premium. That is what that person, these are 2018 quotes. These are honest-to-God quotes for a 58-year-old man. An individual, $18,000 premium every single year, $9,000 for the bronze. You have not seen a doctor yet if you buy that plan. That is for the honor of having that policy. You have received no care yet, and he is 18 grand in the hole. The yellow is deductible. That's what you pay 100% out of pocket before your insurance covers anything. And the red on this policy is coinsurance. That's the maximal out of pocket that the person could pay in coinsurance, co-payments, before their policy really does pick up everything else. So my point on this one is, if you look at this, and in the bronze plan there's no red because their deductible is their maximal out of pocket. So if you took a good year where Charlie, my hypothetical patient Charlie, didn't see a doctor, he is $9,000 better off by getting the bronze plan. In a bad year, in the worst year of his life, he's in the ICU, he has surgery, he's hospitalized, and he maxes out his plans. He bought this plan with the thought he was going to save money. I'm going to buy that good plan because when I access care, I don't want to have to pay much. Well, he's on the hook, to his surprise, for another $6 grand on top of that $18,000. He's on the hook for 24 grand himself. In the worst year of his life with the bronze plan, maxing out the deductible, though it's a high deductible, he's still $7,500 better off than if he bought the gold plan. And what's really fascinating here, and I love making these graphs because you see interesting things, is when he did the bronze plan, if he had the worst year of his life, and you track it over, it's actually less than the premium, what he would pay every single year for that gold plan. So all he's achieved by buying the gold plan is creating the equivalent of the worst year of his life financially every single year compared to buying that bronze plan. Now, to really illustrate how direct primary care saves money, I did a financial year 2017. And what you see here is Charlie. I made Charlie a diabetic. So he has all his diabetic visits. This is what he's charged in insurance world. This is what he's charged under DPC practice. It includes all his visits, all his labs, all his meds the entire year. He even gets an episode of pneumonia. He gets a chest x-ray, he treats it. He gets a follow-up visit. He gets a scare with some chest pain, gets an EKG, Holter, stress test. At the end of the year, his total charged rates under the insurance plan are $5,500 for the exact same services. In fact, I would actually argue better care. We get same-day accessibility, 30-minute to 1-hour visits. We have no financial conflicts of interest. He gets better care under direct primary care, the exact same services, including our membership, $832. That is including the stress test, the chest x-ray, the labs, the visits, everything. His entire year of medical services. Now, some people may say, yeah, but the insurance may cover some of that, and that's true. So let's take a look how this works. So if Charlie were to buy the gold plan under that scenario, under that year, and he saw a traditional insurance-based practice, after spending this mountain of cash on that premium, the honor of having that, and thinking he would pay less when he actually sees the doctor, he still is on the hook for $2 grand above that in charges. Because when people pay 20% on their co-payment of a false price, what does that mean? It means nothing. It's based on a false number to begin with. So Charlie's a smart guy, though. He heard my talk on the fallacy of good insurance, and he bought the bronze plan. Great, saves $9 grand. However, now he's subject to under this scenario where he's still seeing the insurance practice to bad prices. So he pays almost $5,000 of that back. Now Charlie starts getting really bright here, and he goes, what if I combine that inexpensive coverage with less expensive care? Now he's only paying $800 for those services, and now he's already cut his costs in half by $10,000 simply by changing how he's paying for the system. Nothing's being rationed here, nothing's being done different. He's just changing how he pays for it. And what's interesting too, his payments under direct primary care for all those services are still less than his co-insurance under the gold plan. Now, if he's really smart, he starts looking down here at alternative coverage options like the Christian Health Sharing. In this case, I use Liberty Health Share, who partially cover direct primary care. That's why his out-of-pocket's less here. And this is a short-term policy, which are vanishingly small premiums. Now, they don't cover much. Again, they're catastrophic. They'll cover things like hospitalization, major surgeries. Well, that's what insurance is. It's a financial tool to prevent financial calamity. The insurance here is the financial calamity. I didn't steal that from Umbehr. All right, sorry. I'm a little sophomoric at times. So in 1 year, again, by simply changing how he pays for his system, he would save $18,000 in 1 year. That breaks down to $350 every single week. Now, I went to Walmart and I wanted to say, what can you buy? That's a lot of money. What can you buy? You can buy a 55-inch HD 4K sharp LED TV and still have $30 in your pocket every single week for a year with those savings. Or alternatively, $350 is so much you could buy 1,000 of Josh Umbehr's ties. You know how glad I am he showed up? I didn't see him last night. I'm like, oh my God, that's hardwired into my presentation. I'm going to have to pick on Lee and no one to believe it. He's the sharp dresser. All right. Now, this is the important stuff, I would say. Because why does everybody care about prices, right? This is boring stuff. Yeah, sure, it's great saving people money. It's important for ourselves. If you own your own DPC, look at those alternative coverage options. But I think the next couple of slides, honestly, are imperative that everyone in this room understand. Why are prices important? Because of the fallacy of false pricing, high prices, and I think we've just shown it's a fallacy, we can get these things at much better prices than they're billed. Outside entities has used those prices as justification to rob us of our profession. Third parties have come in and said the only way you can afford medical care, because it's so expensive, because prices are high, the only way you can afford care is to pay it through us, insurance companies and the government. And we are told by adding this army of middlemen that will save money. And because prices are high then, these third parties now start saying, but you can't refer to any doctor you want. You can only refer to the small network of specialists, of surgical centers or hospitals. And we're told that that will save money. And because prices are high, we start being, clinical judgment be damned, we start being forced into treatment algorithms, circumventing all your training. And we are told that that will save money. And because prices are high, we start being placed in restrictive drug formularies. You can't use any drug you want, doctor. You must adhere to only the drugs that are on our formulary, for which our pharmacy benefit manager probably has some unseemly relationships with the pharmaceutical company and the pharmacies themselves. And we are told that that will save money. And because prices are high, we start getting roped into risk-sharing arrangements like ACOs, where you can actually be paid more to deny people care, and you're actually financially incentivized under these models. They are financially incentivized to avoid sick people. And we are told that that will save money. And because prices are high, we now have to start collecting value metrics, spending gobs of time, data entry, taking time from patients, putting numbers in computers, and we are told somehow that's going to save money. And because prices are high, we start getting pushed into timely authorization processes where your clinical judgment be damned, you must get approval and sit on the phone with the insurance company, and somehow that's going to save money. And because prices are high, these insurance companies now have to answer those phones and staff up these departments of price saving schemes, and we are told that that will save money. And because these third parties have made all these staff with the price saving schemes, we have to add staff to deal with their departments of price saving schemes, and you know what that does? It makes prices high. Take that, Umbehr. Take that, Umbehr. All right. And this is an example. Blank space. Yes, they're a blank space. Mandates. Mandated treatment algorithms. I love algorithms. I have nothing wrong inherently with algorithms. When I trained in the 90s, they were coming into vogue. And they were clinical tools to assist with decision making. That was it. They had disclaimers on them. This does not supplant clinical decision making. Now they are mandated. So they are no longer tools to assist with complex clinical decision making. They're mandated replacements for clinical decision making. And why? Because MRIs are expensive, prices are high, right? That's the justification. So many insurance companies now if you have a patient with back pain, and I'm not saying you should get MRIs on everybody with back pain, but if you want to get an MRI on a patient with back pain, many times they say, no, you must get an x-ray first. Why? Because MRIs are expensive. Well, is that actually true? Do you remember my slide from earlier? We are able to get an MRI with a direct approach for less than half of the cost the hospital charges for the x-ray, which means that the entire intrusion into our practice of medicine is based on the fallacy that MRIs are expensive. Now, a quick explanation of how our current system is financed, at least for primary care. So one thing that's important to remember is the patient pays for their care. It doesn't matter, you know, it's confused and buried in a complex morass of payments. Premiums, deferred wages, taxes, but in the end that patient pays for their care. And just as strong of the fallacy of high prices is the equal and opposite fallacy that this could ever actually be free. You can bury it in bigger premiums and bigger taxes, but in the end you do pay, but it's hidden. I don't know about you, but I like to know what I'm paying for. So in this example, what you see is a patient pays the government in taxes and pays insurance companies in premiums. And if they're on Medicare, many times they're doing both with supplemental policies. When you pay the government, ironically, the government's plans actually contract with insurance companies privately to administer them. They don't actually administer Medicare and Medicaid. Those are administered by insurance companies. And then eventually they pay the doctor. But each step of the way, they're taking a big cut themselves and putting their own stipulations on the payment. What does that mean? That's control of you. So once that patient does come in, who, remember, paid everything in the first place, come in to see the doctor, where's the doctor's attention? It's on completion of the forms to justify the payment to the insurance, who justifies the payment to the insurance company that started with the patient in the first place. So what does direct primary care do? Gets rid of all this waste and corruption. And it takes it back, now watch the doctor's head, to the focus being where it should be, on the patient. And now some people say, okay, that's fine, but what about the truly indigent who can't afford the $40 a month membership? You know, that's a fraction of a cable bill. You know, what about that truly indigent person? Well, there is nothing about the scenario that says that person cannot receive support from friends, from family, from charity, or yes, even from the government. However, what it does is it not only eliminates a lot of that waste, but it keeps the decision-making in the single most ethical place for life and death decision-making to be made for a patient. And that's with that patient, not by administrators, not by bureaucrats. That decision-making is now made by that person for themselves with the consultation of their trusted doctor. Now to end, I have a confession to make. I really love Josh Umbehr. No, that's not it. That's definitely not it. I have a confession to make. Since I've become a direct primary care doctor, gotta admit it, I've become really, really greedy. But not greedy in the way people accuse us, not for money. Greedy for something far, far more valuable. Greedy for the value of my time. Which ironically, when I was an insurance-based doctor, I was so busy, I didn't have the time to appreciate the value of my time. Time with my patients, to care for them, to counsel them, to comfort them, to help find out what they want from the healthcare system. Time with these guys. These are my kids. And time to watch them grow. Time with my family, time with my friends. But there's one important person missing in all of these slides, and that's this lovely lady here. That's my wife, the pediatrician, who's still in the insurance model of care, and that's because she's here. At our island, night after night, day after day, long after clinics closed, on weekends, in lieu of vacations, charting, doing every ridiculous mandated task that's foisted upon her by the very people who destroyed our system. Don't let that be you. You have a choice. You can chart your own destiny. But though I have been greedy with my time, I've loved the flexibility DPC has given me, and I've taken full advantage of it. I coach my kids' teams, softball teams, baseball teams. I love it. There are an incredible group of people who are selfless defenders of you. Kimberly, Ryan, Julie, Amy, Mike, even Baldy over here. Okay, that one was low. That was low. But they are defenders of you. They have been selfless with their time. Time spent propagating this model and defending you. And in the end, I would just like to say, may God bless all of you. May God help you find the path that gives you personal and professional happiness. And may God continue to bless this incredible direct primary care movement, the last great hope for our healthcare system. Thank you.
How about another round of applause for our panelists here? All right, so we actually are doing pretty good on time. Thanks for the double time, Chad there. So we actually have two microphones set up on stands here, one right there and one right there. If anyone wants to queue up and ask questions, we got some time. Keep in mind that tomorrow's sessions, the breakout sessions, are really where the rubber meets the road to learn about the true details and ask the questions of specifics on how you manage your practice. How do you get lab contracts? How do you negotiate these things? So not the point for today. Today's the motivational, the understanding of the whys and the how, and you know, why we're all here and how this all works. But we're going to go ahead and open it up to a few questions. So right here at the microphone.
Hi, I'm Molly Rutherford. I've been doing direct primary care for 3 years. Tell me if this is not an appropriate question for now, but I just wanted the panel to address Medicaid. If any of you are seeing Medicaid patients, how are you doing it?
Are we on now? Yeah, okay. Yeah, actually, we had an article written about us because of that. I see more patients now as a DPC doctor, and I Medicaid patients than I saw as an insurance-based doctor. The Medicaid system, at least in the state of Michigan, is so incredibly stressed that there are few doctors who accept it. So even the people who tend to be struggling and get Medicaid are usually, we have a lot of them who are willing to pay us on top of that to actually see a doctor. And in our state, at least, we're allowed to still order things under Medicaid. So if that functions as the insurance, and so they'll still honor our orders, at least in Michigan.
Yep, and I'll riff
Kentucky
off that.
says,
So I'm in
Kentucky
Southwest
says that's
Detroit.
illegal, so how are you able to do that?
I'm sorry?
Kentucky says that's illegal.
Illegal. She's saying it's illegal.
Yeah.
It's a state-by-state issue.
I'll riff off that.
Okay.
Just we're in Southwest Detroit, and we have a lot of low-income folks. Detroit is greater than 50% Medicaid, and so many of our patients have Medicaid insurance. They just want the care and the demonstration of care and the time with the doctor, a clean environment, and the ability to ask questions and be understood.
Okay.
And people are willing to pay over and above that out of pocket to see us.
And
No, I'm
I'll
not a
get with you,
panelist, but
like-
I would say here in Florida, we have what's called share of cost Medicaid, which basically if somebody, has no insurance and you end up in the hospital, God forbid, with a major heart attack, you're in the hospital for a week, you run up a $200,000 hospital bill. Medicaid becomes retroactive to the day you walked in the door of that hospital, and it's like a $500 to $600 per month deductible after that. So it covers the hospital bill, and then after that, the patient has Medicaid, which they can take forward with them. But the problem is they can't manage their chronic medical care with a $500 or $600 per month deductible. So those patients seek us out, and so we have many patients with these high deductible Medicaid plans that manage their chronic care through our programs.
I'll
I'm
talk
going
to
to
you
move
later,
to another
Chad. I'll
microphone
get it.
right over here.
I'll talk to you later, if you don't mind.
I would just mention too, as a specialist that in Florida, I'm seeing the Medicaid patients will come in and pay what I call my fair cash pricing. I don't do a membership model. They can't get care for their chronic disease. And so showing up in the ER every few months for flare-ups of lupus or rheumatoid arthritis is not a really good way to get care. So they're very motivated to pay if the prices are kept fair.
Yeah, and I was I was going to kind of expand on that because that's a major savings point too. By having access through DPC, you actually decrease significantly ER utilization, and I was so scared of Lee beating me for running over that I kind of sloughed past that point. But yeah, I mean, that's another cost savings we get. That those, it's funny with Medicaid, they thought ER utilization would go down when Medicaid was expanded, but since a lot of them couldn't find primary care doctors and they didn't have a cost associated with going to the ER, it actually dramatically drove up ER utilization and actually is burning out the ER docs.
Next question over here at this microphone.
Yes, Belen Amat from Grand Rapids, Michigan. Where do you guys see direct primary care in 10 years?
Well, as the smartest Michigan doctor, I think you can probably answer that.
You're talking to Paul? Yeah, I knew what you were saying.
Anyone, any panelists care to address that one?
Yeah, I think direct care is only going to continue to expand. Now it was a small movement of single-digit doctors that has grown slowly each year, but now that momentum is getting to that point of possibly linear, if not exponential. Like Dr. Lee said on the radio earlier this week, just with the attendees here, if everybody started a practice, that'd be a 30% increase in the movement. And if we did that every year, we have 250,000 primary care plus docs, and 1,000 are doing direct care. But now conferences like this are held several times a year with great attendance. Because the system is so broken, they're looking for it. Patients are actively seeking it out. Again, Dr. Lee can attest to when we're on the radio, it almost breaks the website. The amount of patients who call from across the country, very interested, sometimes desperate for this care, telling us their stories about their medication or troubles getting access.
Josh,
So-
would you mind addressing the question we get a lot about, why isn't this worsening a primary care shortage? How does this affect the physician labor, and why aren't we creating a mass shortage in access to primary care? Can you address that, please?
Absolutely. I think it's a false assumption we make. They say we'll have a physician shortage of between 50 and 130,000 doctors by 2025. But then the American Academy of Family Physicians has the most conservative study to say that 22% of our time is spent on non-clinical work, paperwork, EMR, et cetera. And they said if you take that 22% alone and multiply it across the workforce, that's the equivalent of 165,000 physicians, full-time equivalents back in the workforce. So we don't have a doctor shortage, we have an efficiency issue. And we're burning doctors out by spending 1 to 2 hours on extra work for every hour of clinical work. When in reality, in the direct care model, 95% of my day is on patient care. It's the way it should be. So if every doctor did this, roughly 300 million Americans, roughly 500,000 providers who could, under a DPC umbrella, that's 600 patients per doc. So even if it was half that, that's 1,000 patients per doc. We have plenty of doctors, we just have to let them focus on what matters, which is patient care.
And another thing that's always ignored when making that argument is forgetting that that shortage, that theoretical shortage existed before we ever came into existence. So there's an ignoring the whole system that actually set up the shortage in the first place. This is a response to the stresses that created the shortage.
Question over here at this microphone.
I'm Janice Hudson. I'm from Florida also. I will say that I just started my DPC practice, but so many of my patients are actually Medicaid patients who can get free or very low cost care if they can find anybody to accept Medicaid, but nobody's accepting Medicaid. And so they're willing to pay the fee. And I also want to address Dr. Rutherford's question, which is if it's illegal in Kentucky to see Medicaid patients outside the Medicaid system, and there are other states that that's similarly true, how you're going to fix that is bug your politicians, go to your state legislature, demand patients have a choice.
Thank you. Microphone over here.
Chad, we know so many of us humans make decisions out of fear. Fear is a great driver for decisions. For the gentleman in your example, who you explain the financial benefits of a DPC practice, and he says to you, yeah, but what happened? I get hit by a bus. you know, and I got to go to a, you know, surgery and hospital stay for 2 weeks, and I'm, as Lee said, I run up $200,000. That's why I keep my insurance. What do you say to that guy?
Well, that's a catastrophe. You get hit by a bus, that's a catastrophe. That's why you have catastrophic insurance. None of us are suggesting that people go bare, because as a primary care doc, I can't take out an appendix. Thankfully, as I understand the statistics, 95% of people in any given year will not utilize a $5,000 deductible in total. That means essentially only 1 out of 20 years are you using a high deductible health plan. Don't pay like you're incredibly ill every single year when you're only essentially utilizing it 1 in 20. Save so much money. If you think about that case where he saves $18,000, I was talking to a guy who's type 1 diabetic on the way down, and we were talking about this very issue on the plane, and he does insulin, and he's like, my gosh, I'd have to pay for my insulin out of my pocket, and it's, like, $400 a month. And I said, okay, so that's about $5,000, so you're only $13,000 better off now. If you paid that out of your pocket. So and my wife did the same thing. We're part of Samaritan Health Ministries, my own family, and we saved $13,000 the first year. It's actually more than that now. The difference between my old policy and my health share is bigger than that now. And my wife, who's bright, she understands these concepts. She goes, yeah, but we'll have to pay for our physicals ourselves. And I said, okay, there's 4 of us. If they're $250 a pop, that's $1,000 between the 4 of us. Okay, we're not $13,000 better off, we're only 12. So it's just realizing the insane magnitude of waste by getting those more expensive plans. Still have coverage. Bad things do happen. You do want to insure against the rare event. You don't want to pay for the rare event every year.
And just dovetailing on that, that very far right column that Chad showed in his slide, that very short one, those short-term medical plans, the smallest of the small expense. Right now those are being expanded around the country, but there's so much pushback against them, and they're being called junk insurance. And I would actually say that those are actually true insurance. It's probably the only true insurance that is out there right now. So we just kind of got to watch the language that's being used to describe some of these plans. And when we talk about the risk, the financial risk, and I'm not saying we shouldn't have insurance. I love insurance. I love my homeowner's insurance. I hope I never need it.
Cliff Tinsley from Virginia. I'm going to open up in about 3 months, and Emily O'Rourke just opened up. Thank you. I saw the numbers that Chad threw up there, and I'm sure the insurance companies see them as well. So I saw a post that concerned me recently, that insurance companies told a patient that they couldn't have their insurance and see us as well. Did you guys see that, or do you have any comments on that?
Well, like the HMOs, first of all, they legally can't force someone to do that. But if they, as I understand it, I'm not Phil Eskew, so ask any legal, I should clarify, any formal legal advice should go through an attorney. But as I understand it, they can't legally restrict what you do. They can say we won't pay for anything you order if they're an HMO. That is a legitimate issue. Actually, I would really like it if insurance companies, if you are a board certified or whatever, maybe not, but if you're a licensed doctor in your state to practice medicine, I don't think how you're paid should make a difference. I think they maybe still should have an ability to say, oh, you're ordering an MRI every other day on a finger for no reason. We have the ability to say no to that. But they shouldn't be able to say no to you on the sole grounds that they're not paying you, and thus through the payment mechanism controlling you. It's either valid or it's invalid. And I think any licensed doctor in the state should have at least access to an authorization process. But yeah, mainly HMOs are the ones we get kicked back on that kind of stuff.
Ellen, can I toss that question to you? Because as a rheumatologist, you use a lot of rather expensive infusion medications, you order a lot of MRIs. Have you seen any kickback from insurance companies in terms of covering these things, or how do you do that with your practice versus things that are done in the hospitals?
So now I'm opted out of Medicare. I'm at the end of my 3rd year, and for rheumatologists, it's kind of a big deal. I may be the only one that I know of. Actually, there are 24 in the country. I looked that up not too long ago. So in the Medicare population, we thankfully have the ability to continue to order tests, and I haven't seen any pushback. Well, they can't have it done in my office, so they have to go to the hospital, and so that has just been an inconvenience and an expense for them, unfortunately, because before I opted out, I was doing much of that stuff in my office. So I have patients who are now going to the hospital, and they bring to me these incredibly large bills, and they say, well, when I was getting it here, even though they're expensive medicines, there wasn't a big upcharge and a facility fee and everything. So it is an education kind of for the patient. At the moment, I actually am still taking commercial insurance, but I am trying to get out of, starting this coming year, to back off of that and become out of network. So there may be more to come on that.
So, but the irony is by having to send your Medicare patients to the hospital for an infusion that you could have done in your office, they're probably paying 10 times the price for that, or Medicare is paying 10 times the price for that.
There's no question about it.
Okay.
So they cannot threaten to drop their insurance if they come see us?
I'm not sure I understand the question.
Well, that's kind of what the Post implied, that the insurance was going to drop their insurance if they saw a DPC dog.
I'm not going to answer that question, but thanks for the question. Over here.
Yeah, I'm Shennery Cotter. I'm the physician that Hal mentioned in the introduction. And a year ago, I came to this conference having figured out how to make a go without our income for my family because I was ready to quit medicine. So going back to the physician shortage, the primary care physician shortage, I sat through this conference. I cried through Dr. Gunther's talk. I cried for poor Dr. Farago as he signed my book. And sorry. And now I'm practicing medicine in direct primary care, and I'm really happy.
Thank you. Good night. Yes, over here.
Yes. My name is Robert Berry. I'm from Tennessee, and I've had direct payments since 2001, but it's fee-for-service, looking to switch. And I'm also a member of Samaritans, has been for the last decade. I have a question, Chad. Have you, or has any of the policy wonks, figured out how much it would save the economy? Because I've estimated this,
Well,
and
actually,
I come up with about $1 trillion would be added to the, probably more than that, would be added to the economy if there was no insurance payment for primary care.
I think you're spot on, actually, because I did an article in Investors Business Daily comparing what we spend in healthcare to gross domestic products of entire nations. And essentially, we spend as the equivalent in medical care alone in the United States, equivalent to the 4th largest economy, the entire nation of Germany's entire economic output, the biggest economy in Europe, we spend in healthcare alone in the United States. And if you were, and actually almost half of that is based in government payment systems, Medicare and Medicaid. It's about 1.5 trillion. We are terrified of Iran and their ability to get the nuclear weapon. Imagine if CMS gets nuclear aspirations.
But I'm just talking about savings from primary care if you eliminated insurance.
Well, I don't know about the elimination
primary
of
care
insurance.
alone. If that were looked at from
I would say
the policy
elimination of
people.
insurance for things you don't need to insure.
Yeah.
Things that are smaller expenses that should be you able to plan for. An annual physical, if you know you're going to go see your doctor every single year for a physical, do not insure that. Mm-hmm. All you're doing is adding middlemen, stipulations, and cost. That's something that is baked into your premium, no doubt. Oh, yeah. So that's in theory something you could save in premium. And a lot of people, I talked about it being covered up in a morass of payment mechanisms. So many people have it buried in deferred wages. They say, oh, my employer covers this. Your employer didn't cover that. They could easily have given you more wages, but they chose to give it to you as a health care benefit because there's a tax advantage to do that, and that needs to be addressed. We could actually eliminate the employer-based health care system immediately by allowing HSAs to be used for insurance premiums because you immediately eliminate the tax advantage.
We're going to take another. Thank you for the question. Thank you for the question. We're going to take it from another microphone. Thank you.
Thank you for all the great speeches. I really enjoyed them. My name's Thompson Foy. I'm a medical student, and thank you. And I had a million questions, but I tried to narrow it down to some context and a question. So, my granddad was a radiologist, and he started practicing shortly before Medicare became a thing. I guess it was 64, 65, sometime around then. And I know he was my granddad, but he seemed like he knew everything about every specialty. And quick story about him, I believe it was his intern year. One day he decided he wanted to learn about the anatomy of the hand. So he went down to the morgue or cadaver lab, whatever it was, and he cut a hand off and he took it home with him. And he told me, he said, Thompson, I knew the hand. But I guess I'm saying that because now I'm on the wards, and I've gotten, I don't want to say in trouble, but just gotten that disappointed look because I take a little too long pre-rounding. I guess I like to talk to people. And it just seems like so much time is spent coding and all the stuff that I'm sure you're more aware of than I am. So my question is, how do you think direct primary care and direct pay services generally can affect medical education, even from the frame of mind of, say, changing, disrupting, innovating the training process, even like a apprentice-like training system? I think these are kind of big questions we need to be asking.
Well, Dr. Eck actually sees medical students. Dr. Eck is here, and I know she has medical students. We were just talking about that yesterday, and maybe you may want to approach her later, but it sounds like she does a wonderful job, and the only kickback, as I understood from her, is that the medical schools don't like her telling the students about all these options.
Do you do work with medical students in Detroit?
Yeah, so part of my practice, I do have a contract. I'm a clinical assistant professor at Wayne State, and I have a contract with them to host some of their medical students, and I also have a contract with the PA school. And it's really amazing talking with these students and just having the perspective of knowing what the medications cost and what the imaging services cost, and just trying to fuel them to be more inquisitive about, when you're rotating with a physician, how much do you charge for this, or what are the charges you send out, how much are you reimbursed for this, to help them understand the context of the cost of medical care. And also, just speaking at the medical school, I know that students really get turned down and amped up about direct primary care and wanting to understand how to deliver medical care on their own terms without these limitations. So I guess the challenge would be for the people in the room, which medical school is nearest to you, or PA school, or which NP school, or which residency program is near to you, and how can you get into those walls and tell the story of direct primary care and inspire the next generation of people?
One of the hardest things for students to understand is that direct payment mechanisms are not lacking compassion. Because most people say, well, if you want to do that way you're clearly not empathetic, you don't want to care for poor people and stuff, and that's not, this is a debate about what is the most efficient way to run a healthcare system. We can take care of our sick. In fact, I would hope everybody in here wants to take care of everybody who's sick. It's just altering how we pay for the system and how we do it to the most efficient, lacking coercion and waste, system, and the direct method is much more efficient.
We have time for one more question, so I'm going to ask you relinquish that microphone there. There's one person standing right behind you.
I just have to say one more thing, and it'll take 5 seconds. I'm the redneck who shouted Alabama earlier, so. I'm here with the Benjamin Rush Institute, and we have a booth outside, and we spread the word to medical students. So come see us if you think that's something that's worthwhile. Thank you.
Thank you.
Hi, good morning. I'm Jessica McCain. I'm trying to finalize my business plan for a clinic in Fort Pierce, Florida. Anything free market. My husband is an economic kind of guy, so it really turns him off. My parents, on the other hand, turns him on, I mean. My parents, on the other hand, are turned off, and they verbalize their concern that DPC just won't support me in our community because our average household income is $25,000, our average individual income is $17,000. So what I wanted to get out of this is kind of a spiel. What can I tell patients? If I'm in line at the bank, for example, and I have 1 minute and I can't show them these great presentations and the graphs that show the economic savings, the Medicare patient, 64 years old, they've paid into it. They've waited their whole life just to get that present of Medicare. They can't see spending again for insurance since they've earned the Medicare. What do you tell them to encourage them to seek your type of practice? Thank you.
We have 2 minutes.
I think the poorer and sicker you are, the more you need this model. The system is set up for successful people to use it. If you don't have a car, you don't have car insurance, you don't have gasoline, if you have to take 3 buses and 2 stops and you've got a migraine and you've got to try to get to your doctor before your next shift, that's hard. That's the system, accidentally leaving a lot of people out. but when your doctor will take a phone call, a text message, an email. I have a diabetic patient sending me a picture of her foot ulcer every day so that we can manage it, and she doesn't have to do anything extra. She's getting high amount of care, very straightforward. So you show them the value, and I think that the more value you generate, the more gravity it pulls to it. Medicare is wonderful at what it pays for and awful at anything it decides to not pay for. So wholesale medicine, there's a medicine that's $66 a pill that Medicare won't pay for that we can get for 19 cents a pill. So we can show the patient that value in 2 or 3 pills. They don't lose anything by joining with direct care and using it alongside of their Medicare, but there's a lot of things Medicare leaves out and a bunch of cracks in the system. So
one of the things I would encourage you to do, I can't see the last questioner, but tomorrow's sessions, part of that is going to be learning sort of an elevator pitch. I think that's really going to be an important thing, and so we'll definitely work tomorrow on the marketing and how to make that sale quickly. So look at the schedule for tomorrow, but you'll definitely see that session in there about marketing yourself, how to make that quick pitch. All right, a little bit of housekeeping here. Phil Eskew took the red eye in from Wyoming, so he was running 3 hours late, but I have word that Elvis is in the building. So so we're going to go ahead and take a 15-minute break. We want to start back sharply at 10:30. Let's try to keep this on schedule. Give our panel a warm round of applause. Thank you so much.